Once again, welcome to Cornea Care. In previous Mural's video, we mentioned that many systemic diseases can cause PUK. Out of these, rheumatoid arthritis is the most common. RA can affect different ocular tissues. Most common is lacrimal gland involvement, followed by scleral inflammations, then anterior uveitis and corneal pathologies. Out of various corneal manifestations, we will restrict ourselves to two presentations. One is typical PUK, which is a peripheral, crescent-shaped infiltrate with overlying epithelial defect. Since it's an immune-mediated pathology, topical steroids and systemic immunosuppression is required. When this PUK is associated with scleritis, it indicates that the disease is very severe and needs very aggressive treatment. Second is stromal infiltrates. These may be of variable shape and depth. Location may also be variable. Overlying epithelium is usually intact initially. We are clubbing it with PUK as the underlying immune mechanism is same in both pathologies. In fact, stromal infiltrates may be a precursor of PUK, but PUK treatment is more intensive as the disease is more aggressive, as we will see in next two short cases and one long case. A 53-year male was referred for right eye redness of recent origin. He was a known case of RA for which he was on methotrexate 7.5 mg. His right eye had a linear greyish-white peripheral infiltrate with some areas of overlying epithelial defect. Other eye had few inferior SPKs and one filament. Right eye infiltrates appeared immune-mediated as it was peripheral greyish-white except one area which appeared yellowish-white. This area was scraped to rule out secondary infection. We started antibiotic too early and mild steroids 4 early. He was advised rheumatologist opinion as these episodes signify the need to enhance the oral immunosuppression. 2 days later, there was no epithelial defect and infiltrate was negligible. Antibiotics were reduced and steroids tapered. I would like to mention that the choice and dose of steroid is determined by the extent of infiltrate. Physician suggested ESR and CRP to assess his RA status. In 5 days, infiltrate resolved completely. His methotrexate was increased and a short course of oral steroids was given as these episodes signal that systemic disease needs to be better controlled. Coming to second case where disease severity was more. This lady came to me long back during my early years of practice when many rheumatologists were not available in private practice. Her complaint was left eye redness. She had lost right eye vision after a similar episode 3 years back when glue BCL was done elsewhere. She was a known case of rheumatoid arthritis for which she was under treatment. I noted right eye adherent glaucoma and a small linear arc-like epithelial defect and infiltrate. I gave her intensive steroids. I kept the dose of steroids high as there was history of rapid worsening in the right eye 3 years ago. She was better after 3 days as defect healed. We started drug tapering and she did well for next 9 months. Then she came with another episode. This time both eyes were congested, but left eye had multiple anterior to mid-stromal infiltrates with intact epithelium over most of them. Thankfully, there was no scleritis. She revealed that recently there was some cardiac issue for which she had stopped her oral sulfasalazine. Since these appeared typical immune-mediated stromal infiltrates, scraping was not done. She was started on intensive topical steroids and advised urgent rheumatological opinion. During follow-ups, she used to have occasional flare-up. Her IOP increased once, requiring addition of glaucoma medication. Ultimately, this eye also had a small central melt. Retrospectively, I feel that she never received good immunosuppression. Now, we are lucky to have an in-house rheumatologist, which is a big boon, as we will see in the next case. A young male of 43 years was referred to us for management of bilateral Moran ulcer. He was a carpenter in Saharanpur, a 2.5 hours bus journey from my clinic. His history was of 6 weeks when he started treatment in his own hometown. At the time of referral, he was on antibiotic and lubricating eye drops 6 times a day. His right eye had a peripheral epithelial defect and whitish corneal infiltrate from 11:30 to 3:30. Outer edge of this infiltrate had 80% thinning. There was another 2 mm central epithelial defect without infiltrate. His left eye had a peripheral epithelial defect and whitish infiltrate from 1030 to 230 and an area of iris prolapse about 2 by 2.5 mm in size. These peripheral white infiltrates were indicating immune pathology, but clinically they were not looking like Moran. He had history of joint pains but never had consulted for that. We planned a rheumatological evaluation. Both eye peritomy and glue BCL were planned. We were aware that the left eye might require patch graft. Our rheumatologist suspected RA and advised few blood tests. The extent of disease demanded prompt immunosuppression, so IV methylpred 1 gram was started. Oral Ciplox was also given in view of perforation. Peritomy and glue BCL were done in both eyes, but scraping were taken only from left eye. Here the prolapsed iris was covered with a piece of eye drape and post-op antibiotic steroids were started. He received total 3 doses of IV steroids. Based on his blood test and clinical symptoms, he was diagnosed as rheumatoid arthritis and started on weekly dose of 15 mg methotrexate. Post-IV steroids, he was shifted to oral steroids and calcium supplements. Post-op, he did well. He was on close follow-up. Oral and topical steroids were slowly tapered. He did well for 5 weeks. He was asked to take monthly dose of calcium binding agents as it is advised in all patients with long-term oral steroids. Medication was further reduced and he was called for follow-up after a month. But he was back within 3 days on a Friday. His right eye was fine, but left eye had a flat AC despite glue BCL in place. He was not sure about trauma, whether he has rubbed his eye due to irritation. When we told him the need of repeat procedure, he refused on the pretext that he is having anxiety as he has come alone and wanted to come with his wife next day. Unfortunately, he did not come next day, rather came back after 3 days. By this time, there were anterior stromal infiltrates also. Now he told us that he has not used his antibiotic steroid combination for last 6 days. At this juncture, we did not want to take chance by only increasing topical steroids, so we gave a repeat shot of IV steroids also and increased the methotrexate from 15 to 20 mg. We did repeat glue application but failed this time. We made another attempt next day, but that too failed. We decided to go ahead with patch graft, and secondly we again consulted physician. Because till now we were treating him as RA only, physician advised ANA and ANCA so that in case we have missed some other connective tissue disorder. Patch graft could not be done as the next day he developed very high IOP despite very shallow AC. Oral acetazolamide was given. His blood test reports came negative by that time. When his IOP came under control, only then patch graft was done. AC was well formed post patch graft, but it was shallow superiorly due to PAS. Gradually IOP settled down. Oral and topical steroids tapered, but his left eye required anti-glaucoma medication. On 25th January, 1 month post patch graft in left eye, right eye was doing well and glue BCL was removed, but in the left eye the vision dropped drastically due to cataract. There was still epithelial defect over the patch graft, so BCL was retained. Epithelial defect took 6 weeks to heal completely. Gradually sutures became loose and they were removed. In mid-April we planned cataract surgery. By this time his oral steroids were 10 mg. In view of extensive superior thinning, temporal clear corneal phaco was planned. Even here course was not simple. Just after making the ports, eye became very hard and iris prolapsed through ports. We had to abandon surgery. Malignant glaucoma was suspected. Injection mannitol 300 cc was given. Ultrasound was done. We could not find any aqueous pocket. Diamox and glycerol were given thrice a day. So on 7th May, we resumed surgery. Again the eye became hard, so vitreous tap was done, and only then with the God's grace I could complete this surgery. With intumescent cataract removed and well-placed IOL, I expected pressures to calm down, but it did not happen. He was advised to consult a place for glaucoma valve, but he refused. We hope that with good systemic control of RA, right eye keeps going on fine and he is able to carry out his livelihood. All these are not easy cases. And secondly, chances of secondary infection are always there. Steroids and BCL also predispose to infection, so a close follow-up is must in all these cases. Thanks for giving your valuable time.